All right, so again, hello everyone, and thank you for the opportunity to moderate this case discussion. My name is Zachary Crees, and I'm one of the Hematology Oncology Fellows at Washington University School of Medicine here in St. Louis. And I have the pleasure of presenting the following two cases to our distinguished discussants, Dr. Callender, Dr. Schroeder, and Dr. Gerald. And as we make our way through each case, I'll try to direct some targeted questions to each of our discussants. And at the end of each case, we'll also have the opportunity for the whole panel to be weighing in on these two cases. So we'll go ahead and get started. First, we'll start with case number one, a 62-year-old female with osteoporosis who presented with 5 months of low back pain. She initially sought care from a chiropractor as well as an orthopedist who ultimately treated her with steroid injections and offered no relief really for her back pain. So she was seen by her primary care doctor who ordered an MRI with images here showing multiple level compression fractures. And so with her history of osteoporosis, the initial concern was she should be treated with a kyphoplasty. Unfortunately, during her procedure, she had a bone biopsy done, and that was reported out as showing 60% plasma cells. And so, of course, this prompted an additional myeloma workup. And we can see some of her lab data here. Her hemoglobin, creatinine, calcium, albumin, beta-2 microglobulin, and LDH were all within normal limits. Her serum protein electrophoresis showed a 1.5 gram per deciliter monoclonal protein. Her serum light chains were normal. However, the skeletal survey showed multiple lytic lesions in multiple areas here. And on a bone marrow biopsy, it showed 50% CD138 positive kappa-restricted plasma cells with normal cytogenetics. And so with these data, the diagnosis of multiple myeloma was confirmed, and the patient was categorized as having ISS1 or revised ISS1 staging. And so with a patient like this presenting with low risk disease and minimal medical comorbidities, there's obviously different options for induction regimens that we've already been discussing this morning. Some may favor bortezomib, lenalidomide, dexamethasone, while others may favor carfilzomib. And then as Dr. Gerald alluded to, there are 4 drug regimens. And so maybe Dr. Callender, if you wouldn't mind starting us out, share with us what you might recommend for an induction regimen for this patient.
Yeah, I just very quickly for your audience, I think this kind of presentation actually is not uncommon when people are sort of thought to have osteoporosis for a while, and it turns out to be something else. I think everybody here probably on the panel has probably seen this multiple times. So we always are on the lookout for people who just don't seem to fit that category. But in terms of induction regimen, I think that there's pretty convincing evidence from the recent ECOG trial comparing VRD to KRD, that is Velcade, Revlimid, and dexamethasone, to carfilzomib, that there's certainly, for a person who would have what we would consider low risk disease, very better safety and an equivalent result in terms of effectiveness with a VRD regimen. So that's what I would pick for this patient. Otherwise, if they wanted to go in a trial using a 4-drug combination, that would be reasonable. But off a trial, I would opt for VRD.
Excellent. Thank you, Dr. Callender. And that is exactly what this patient ended up getting, VRD. Ended up getting 5 cycles for logistical reasons. And their response assessment showed that their serum free light chains remained normal. Their UPEP didn't show any monoclonal protein, but their serum protein electrophoresis continued to show 0.3 gram per deciliter monoclonal protein. The bone marrow biopsy showed less than 5% plasma cells. And so this patient was categorized as having achieved a partial response. And so at this point, some might favor more induction therapy until a maximum response, while others may opt to just proceed with transplant in a PR, where others may also favor a delayed auto transplant at first relapse. So maybe Dr. Schroeder, would you mind sharing what your next steps in management of this patient would be with somebody only achieving a PR after their induction regimen?
Yeah, sure. So again, response in this setting, when we talk about partial response, that means a change in your protein level from the myeloma. So it was a 50% reduction, but didn't grit down to 90%. We know deeper response associated with time until the myeloma progresses. This is a patient that is standard risk, and just to highlight how we would determine standard risk in this case, this staging system has to do with the labs initially. So they had a normal or range beta-2 microglobulin. They didn't have high-risk genetic changes in the myeloma. The problem with continuing on the current therapy until we achieve a complete response, is that it's going to be harder to collect the stem cells. So in this case, I think it's reasonable, they've had a partial response, is to try and collect stem cells for a transplant. The longer you're on Revlimid, the harder it is to mobilize those cells and collect those cells. So I would focus in this case, after 5 cycles of the initial induction, collecting the stem cells. And because they've had a partial response and they're in the standard risk category, moving on to stem cell transplant after.
Excellent. Thank you, Dr. Schroeder. And again, this says exactly kind of how things proceeded. The patient was mobilized and taken to an auto transplant. And at their day 100 assessment of their disease status, they were found to be in a complete response, fortunately. And so now it raises the question, and one that all of our speakers so far have kind of touched on, is maintenance therapy. And so with the patient being in a complete response following transplant, Dr. Geralt, do you mind kind of sharing with us how you manage patients to achieve a CR after transplant? Do you consider tandem transplants in some people? Do you favor alternative consolidation regimens, or would you move to a more maintenance strategy?
So the standard of care, this is a great case because it really is something that we have to address every day. So the standard of care across the United States now is lenalidomide maintenance until progression, based on the randomized trials performed both here and in Europe, in which, you know, lenalidomide maintenance until progression was associated not only with a progression-free survival benefit of almost 2 years, but a survival benefit of, a significant reduction in risks of dying at 7 years from myeloma. So I would advise the patient, look, the standard is maintenance at this time, and you should be getting maintenance with lenalidomide 5 to 15 milligrams, 21 days out of 28. Many of our audience may be hearing different things in different centers. This is a patient with relatively low risk disease. If the bone marrow showed MRD negativity, you could actually make the case that this patient may actually benefit from just observation and not need to expose them to Revlimid. That is currently a question that is in the clinical trials, whether we should be doing MRD-directed treatment, such as what Dr. Schroeder was talking about. But the standard, and I would, in this patient, because of the fact that she failed to achieve a complete remission to induction, which was, the best drugs available at that time, I think lenalidomide maintenance would make sense with careful monitoring post-transplant, which is also essential. Patients have to be monitored, at least every 3 months with blood, and then maybe once a year with bone marrow to see what the status of their measurable residual disease is.
Excellent. Thank you, Dr. Geralt. And that segues actually very nicely into the kind of last point or last opportunity to answer some questions for everybody here. So this patient was treated on a maintenance regimen on a clinical trial with lenalidomide plus daratumumab, and they were randomized to the treatment arm, which is comparing lenalidomide alone, as Dr. Geralt mentioned, to this combination regimen. And I'll just highlight the schematic for this study included MRD assessments following transplant while on maintenance. And so I wanted to pose the question to everybody, as Dr. Geralt already kind of very well put. How are you guys using MRD-based treatment assessments, or excuse me, MRD-based assessments to modulate or to inform your treatment recommendations for patients?
So this is Natalie again. I would just say that I think MRD is still a research question, and I am not sure that we know enough about MRD. First of all, MRD is not just a single thing. There are different ways to measure it. There are different depths that you can explore. And I think studies like this SWOG study 1803 are really important to help us try to uniformly assess this. And so outside of a clinical practice, I am not sure that it is appropriate to use MRD for decision-making, but that's my opinion.
So I'm going to echo Natalie, and with the one exception. So the place where I use measurable residual disease to make a decision or to inform patients is patients who are having significant side effects on lenalidomide maintenance or who want to come off lenalidomide maintenance. I tell them, let's do a bone marrow and measure measurable residual disease, because what we do know is that in patients who are MRD positive, stopping lenalidomide, those patients will tend to relapse within 24 months. Now, mind you, you can recontrol them later on. So this is really an individual decision. And I've had patients who simply say, I can't stay on lenalidomide even if I'm MRD positive. I'll just wait. And when the disease comes back, we'll retreat it and recontrol it.
Yeah, and I would try to add to this discussion that I agree completely that using MRD currently off of study for this particular patient may not be the best approach. And this is one example of a clinical study. This patient could have been considered for a clinical trial up front in their treatment as well, if one was available, and that would have been equally acceptable. I just want to encourage all those listening that clinical trials like this, or ones earlier on or at the time of relapse, are always going to be active treatment and well-designed like this study to answer questions. This study in particular is going to try to answer that at the 2-year time point, is it okay to stop maintenance if you're MRD negative or positive? So somebody participating in this study is going to, have the advantage of having access to MRD testing, which may not always be performed. At our center, we are testing for MRD primarily in patients that achieve a complete response. And we're using it prognostically, not to modify treatment. But in this study, you are actually going to be potentially randomized to the standard lenalidomide, or you get the standard plus daratumumab. So it's a really nice design study. And then they're going to adapt the treatment afterwards based on your MRD status, which is cutting edge novel therapy, I think, in the realm of myeloma. And I would sign any of my patients up for this study for sure.
Thank you, everybody. So we'll go ahead and move on to case number 2. So case number 2 is about a 62-year-old male with hypertension, sleep apnea, a history of papillary thyroid cancer that's been completely treated, who's presenting with 2 months of weakness and left jaw numbness. So the patient underwent a CT scan of their head, which was read as unremarkable, but then they had a brain MRI to follow up the CT scan that showed what the radiologist characterized as a, quote, marrow replacing process. So the patient underwent a bone marrow biopsy, and from the outside hospital report, we were informed that it should increase plasma cells and not additional information otherwise. So this patient then got an additional myeloma workup, and I've highlighted and bolded the abnormal values for all of our viewers. So the hemoglobin was low at 9.7, creatinine mildly elevated at 1.31, calcium was elevated at 11.7 and was even higher when corrected for the low albumin of 2.6. And they had an elevated beta-2 microglobulin and LDH. Their serum protein electrophoresis showed a 5.4 gram per deciliter IgA lambda monoclonal protein, and they had a concomitant elevation in their lambda light chains with an abnormal kappa lambda ratio. Skeletal survey was actually without lytic lesions, and on bone marrow biopsy, it demonstrated 20% CD138 positive lambda restricted plasma cells and normal cytogenetics on this patient. And so for this patient, they arrived at a diagnosis of multiple myeloma with ISS stage 3 disease and revised ISS stage 3. And they underwent an induction regimen that included carfilzomib, lenalidomide, and dexamethasone. Unfortunately, the first cycle was complicated by a rash, which was attributed to lenalidomide, and therefore the patient was transitioned to carfilzomib, cyclophosphamide, dexamethasone for 2 cycles and had persistent disease on their surveillance assessments. And so with persistent disease after 3 cycles, Dr. Callender, would you mind sharing with us how you might proceed? For example, would you continue with KCD, or would you change to something else in this setting?
Right. I think this actually points out an area where we have a great lack of knowledge, and a lot of this is driven more by opinion than what we know we should do. I think given this scenario and given the fact that the person has revised ISS stage 3 disease, I think most people would be uncomfortable leaving that current regimen. And that is particularly, as I mentioned, that Forte trial, carfilzomib, cyclophosphamide, dexamethasone did not perform as well in the long run as carfilzomib, Revlimid, and dexamethasone. But what we really don't know yet is, should you change all of the drugs or just start thinking about adding in or change or a different class? And by that, I mean, many people in this situation would probably go to a CD38 antibody inhibitor, such as daratumumab or isatuximab in combination. And then this is where it gets tricky. Some people would say, well, it seemed like carfilzomib should be better, but maybe I should go back to Velcade, or they didn't tolerate lenalidomide, so I'm going to put pomalidomide in with that. I think almost everybody would be uncomfortable. Now, in reality, there is an older retrospective study from the Centers for International Bone Marrow Transplant Research that actually showed patients who go into a transplant in this situation didn't actually benefit from having a switch up of their therapy, that they still seem to benefit as much as a patient who did have a change in therapy, albeit that study included an era where we don't have nearly the drug choices. But I think most people would probably bring in a CD38 antibody at this point and probably try to challenge them as well with pomalidomide, but I'll be interested to see what other.
So it's interesting that, and so I'm the oldest one of the panel, so I can say history here. Initially, before all these drugs, when people were resistant to VAD, it was demonstrated that the best way to get a partial response was actually expose them to high-dose melphalan. So, and this were a series of studies that were performed at MD Anderson with Dr. Alexanian. And what he demonstrated is that, you know, high-dose melphalan can overcome the resistance of, you know, can really get rid of a significant amount of resistant myeloma cells. So in somebody like this, we would do DSEP, collect ×2, collect stem cells, take to high-dose melphalan, and then post-transplant, we would have a series of what we call, you know, maintenance trials for people with high-risk disease that he would qualify for. I do think that that's a reasonable option, but I also agree with Natalie that with the advent of CD38 monoclonal antibodies, I mean, it makes sense to prepare that, is try those agents now. And if they get a response, then proceed to transplant. But if they don't get a response, I think the most important thing is that patients with primary refractory disease should probably at least try to get exposure to high-dose melphalan. These are very rare patients now, by the way.
Excellent. Thank you, Dr. Geralt, and thank you, Dr. Callender. And as both of you—
I don't know what, I'd like to hear what Mark thinks.
Oh, Mark.
Thank you, Dr. Geralt. Yeah, so I mean, just to highlight again, this is a high risk case of myeloma because it's IgA myeloma, because it had elevated beta-2 microglobulin, elevated LDH. That's why they got the revised ISS stage 3. This is a similar approach for the initial treatment that we would have taken. And I think that using daratumumab or CD38 targeted agent to try and get at least a response prior to collecting stem cells is what we would do here. And Zach has already moved on and shown me that my choice was wrong. And they have persistent disease. Okay, thanks, Zach.
No. I think that all of you guys were thinking the same thing, and this is exactly how this patient was managed, that we favored a CD38 monoclonal antibody with some changes in the induction regimen with the hope that we might be able to induce a remission. And unfortunately, the patient proved us wrong and continued to have persistent disease. And so that brings up then the follow-up question of, again, next steps in treatment. And as Dr. Geralt and everyone has already kind of started to allude to, there are other options that one might consider to patients who are not responding to multiple lines of upfront therapy. So in the interest of time, I'll kind of let the cat out of the bag. So this patient got one of the regimens that was already recommended, or actually both of the regimens that was already discussed. They first were treated with DSEP for 2 cycles. Unfortunately, as Dr. Geralt alluded to, did have a partial response. So they were chemosensitive, and then were taken to an autologous stem cell transplant. And at their day 100 response assessment, their SPEP still showed a small detectable IgA lambda monoclonal protein on immunofixation that was not quantifiable. Their bone marrow biopsy was read by our very astute pathologists as showing no overt disease by immunohistochemistry, but when they looked at the plasma cells, they thought that they looked morphologically suspicious for still low-level plasma cell neoplasm persisting in the bone marrow. And so this patient, based on their M protein, was characterized as having a very good partial response. And so after treatment, they were started on maintenance daratumumab, pomalidomide, and dexamethasone, and unfortunately relapsed 6 months after their auto transplant with a rising M protein. And so this then brings up the challenging clinical cases where, fortunately, they're less frequent, but we still see patients with aggressive high-risk disease who are just not achieving optimal responses on treatment. And so I opened this up to the panel, and just for the sake of discussion, I included the ISS and some cytogenetic abnormalities for our patients to look at. These are the things that we're looking at. But I wanted to hear from the panel, how do you guys define high-risk disease? Do you focus on these scoring systems that we have? Are there other things you take into account? And what's your approach for these sorts of patients that are really the most challenging ones to treat?
Well, I think one thing that everybody will probably agree about, we use these staging systems and they're helpful, but I think we also run across the patients who start off looking like they should have, standard risk myeloma and should do well, but after an auto transplant, like this particular case, 6 months later, their disease is back. So I think you look at both some of these initial characteristics of diagnosis, but the behavior after you start treatment, I think, is also something that you have to take into account.
And so this patient would qualify for a series of high-risk trials that we're organizing. And one that Dr. Callender is going to be doing through the BMT-CTN for the high-risk patients. So after the transplant, the patient would be getting a BCMA-directed CAR-T in a way that to try to reduce tumor burden and prevent the disease from coming back. If the patient were younger or fit, we would think that this patient might qualify for an allogeneic transplant, also on a clinical trial looking at novel maintenance strategies with BCMA-targeted therapies. So I think yeah.
Yeah, if Mark is there, I think we would all agree that, boy, we'd be looking for a clinical trial for somebody in this particular situation.
Yeah, I completely agree. I mean, and to highlight in all these cases, these are potentially real examples of patients. Everybody is individual how they respond to treatment. So just because you do have, and to come back to that, the high risk versus standard risk myeloma by these staging systems, I think your response to therapy also is important in determining what to do next. And we know if you go on to auto transplant and you have the disease progress early after auto transplant, that's associated with a worse outcome. And those are the patients really to focus on novel therapies, especially this patient that's progressed on some of our best agents. Looking into a clinical trial is completely acceptable. Looking into immunotherapies like CAR T cells or the antibody studies is completely acceptable, in my opinion, for a patient like this. This patient could be potentially considered, based on long-term follow-up of the CTN study, for a second auto as well, but potentially tandem auto.
And I guess it's important for the audience to know that if the patient did not want to proceed to clinical trial, there is now a drug commercially available for these patients, which is belantamab, which has ocular toxicities, requires an ophthalmologist to see the patient before getting the drug every month, but it is indicated in this situation.
Thank you all for your excellent discussion points. And I want to thank all of our myeloma patients, really, and their families and their caregivers for all of the incredible stories that you all have and for allowing us to participate in your care. I want to thank the participants and the attendees of this case discussion in this first session of the presentation today. I want to focus some thanks to Dr. Vidge, Dr. Callender, Dr. Schroeder, and Dr. Gerald all for really an excellent discussion and sharing their expert opinion on how they would manage these patients and how they approach multiple myeloma. I want to thank the myeloma crowds and the Crowd Care Foundation, as well as HealthTree, for helping to organize this. And a thank you again to all of the sponsors who helped make this possible.